Okay, thanks Roshmi for this IC. Well, I was asked to talk on how does the American Joint Committee on Cancer Classification, rather the TNM, help in eyelid malignancies. And I'll start with a few cases. This was a 65-year-old gentleman with a large mass. He had a prior surgery 2 years ago, and there were no prior reports that were available to us. And if you invert it, the prior speakers, Savary has kind of clearly delineated. But what I'm trying to is you measure, and the largest tumor dimension, the LTD, was 17 millimeters. And the other characteristics which pretty much suggested that you had a lesion, but the good thing was we could see the posterior margin, which seemed to be clinically uninvolved. There was no regional lymphadenopathy. So based on what we saw, the largest tumor dimension and the fact that clinically the lymph nodes were normal, we put it into the 7th edition AJCC, and this is how it looks. Now, basically, from the last edition, 6th edition, what has happened is the T1, in fact, the tumor size is like 5 millimeter, but something additional things have been added. That means you would see in the T1 that not invading the tarsal plate and the eyelid margin. The T2 has been again divided into any tumor that invades the tarsal plate, whereas the B would be anything, any size, but or involves the full thickness eyelid. And again, the T3 would be any perineural invasion. So this particular, those are the things that I highlighted. This particular lesion was T2B, NOMO. And just quickly about now, in 1968, it was actually the International Union Against Cancer which brought up this TNM on the tumor node metastasis. And well, quite expectedly, the eye did not feature in that classification at all. It took several editions. I think it's the 4th to the 5th edition where the eye featured for the first time. The 6th edition had still was used, but more selectively. But actually with the 7th edition, we've had now 6 ophthalmic sites, which include the eyelids, the conjunctiva, the uvea, the retina, the orbit, and the lacrimal gland. And you include 5 cancer types, which is carcinoma, sarcoma, melanoma, retinoblastoma, and lymphoma. And the big inclusion is actually lymphoma, where it actually involves 3 different ophthalmic sites and brings them into the TNM classification for the ocular and adnexal lymphomas. We had done some work on the ocular adnexal lymphomas on the TNM. Okay, so based on the what we had was the T2B, and we had a complete tumor excision which was wide. We sent the margins separately, and the conjunctival map biopsies were sent. We had significant suspicion that this was sebaceous, and that's what it turned out to be. Eventually, well, all margins and map biopsies were negative, and this particular patient is what we reconstructed. This is, we don't have a follow-up beyond 6 weeks, but well, we did a reconstruction with tensile semicircular flap. He did well. Another case, 47-year-old male who had this lower eyelid lesion, and there was a full thickness wound. And interestingly, he mentioned to me that this particular thing had been there for 10 months, and it had several local practitioners seeing him. The size was about 12 millimeters in this largest dimension. It was the medial half of the lower eyelid. And on the day he presented, he actually asked one of my fellows to take a small little wedge biopsy so that we could proceed further. And interestingly, she took a very small biopsy, and that was sent. And this is the lesion seen a little bit on higher magnification. You see it's actually full thickness of the eyelid that is involved. And the first biopsy that came in actually mentioned from the pathologist that there was no malignancy at all. There was no cytological atypia. It was just a focal ulceration. Well, looking at the fact that there was clinical suspicion of a malignancy was very high, I thought, well, this 10 months been here definitely doesn't look, and it has a full thickness involvement. We just went for a full thickness excision and sent to the pathologist. And sure enough, when the next one came, it had the typical, there was a focal ulceration, but it had those peripheral palisading and the nodal pattern. And this was suggestive of a basal cell. And well, the management that we did was, we had a lateral margin was initially positive, so we ended up taking additional tissue, which eventually turned out to be, so we had a negative margin finally. And then again, reconstruction, we did a huge flap for this, and that's the patient after 24 months, no recurrence. Case 3 was an interesting 45-year-old male. Now, he came with this drooping of eyelid, and that was for 3 months, a fairly short duration for that kind size of a lesion. And this was extremely tender. I remember that it was very difficult to even evert his eyelids, even by putting a few proparacaine drops. And this was the eyelid mass, and it seemed to be involving the full thickness. If you really see it carefully, it tended to actually involve the full thickness, and the skin here seemed to be involved. The lymph nodes were, however, clinically normal. Now, we did manage to, this is actually before the surgery, we did this, we actually saw that even the phonics seems to be involved. So this particular case, I wasn't even sure that we would be able to dissect it. And so there was a suspicion of clinically the conjunctival phonics being involved. The lymph nodes were normal. I asked for imaging, and that's the imaging. And you see this pretty much a preceptal involvement. When you look at this, I was not very sure of what we would. So basically, I talked to the patient that, you know what, I would probably go ahead, and we had a Crohn's section available by this time, and we would go ahead and plan an excision. But if it comes to a point where we are not able to, then we're probably dealing with something which is invaded already into the orbit. And based on the classification we talked about, this was T3A and NOMO. Interestingly, because there was a suspicion of the fact that this was probably going, to make things easier, I actually talked to the patient that we would go ahead with a neoadjuvant chemotherapy. And this was given, 1 cycle of neoadjuvant chemotherapy. In this particular patient, however, he didn't take the chemotherapy very well. He was admitted, and he had a long time of admission in the hospital, several problems, and ultimately to the point that we didn't really see a response, and the medical oncologist had his reservations about a 2nd cycle of NACT. So ultimately, he was there with me pretty much with the same lesion, and we went ahead with tumor excision. We had frozen section control at that time. Fortunately, we got a negative margins, and we also had sent conjunctival the map biopsies. What this was interesting was it had features which are pretty much suggestive of sebaceous. But the other thing was, the pathologist told me there was just a large number of infiltration of polymorphonuclear neutrophils, which was actually probably, and we didn't really know what this was, but this was probably responsible for the intense tenderness that the patient had and pain that he complained of. The interesting thing is, I actually had asked the patient that probably look also for, there's a possibility of a perineural invasion, could explain the clinical symptoms, but we didn't find any. And so that's follow-up after 12 months, and that's the same patient, and there was no local regional recurrence. This is case number 4, and 64-year-old man. He had a history of prior excision, and there was a biopsy of, this had suggested a sebaceous carcinoma, and we had a large fungating lower eyelid mass, and you actually couldn't see the eye inside. And that's the CT scan. You can see a massive lesion which is invading into the orbit. And again, ipsilateral submandibular lymph node was enlarged. So this is what the previous, so this is a slide of the previous biopsy that had been done. And again, sebaceous margins were not sent at that time. This was a tumor which was T3B because, well, you had no other way but to possibly think of an exentration. This was a patient we had seen in 2009. Regional lymph node metastasis was present. We gave neoadjuvant chemotherapy, 1 cycle, cisplatinum 5-fluorouracil, and that's the patient after neoadjuvant chemotherapy. I remember he had come after several months, and the tumor had actually disappeared. And because I was seeing him after some time, he had missed subsequent visits. I asked him, you know, where did you get the surgery done? And finally, to realize this is how it was, the CT showed actually some haziness here, and that's why we thought it would be better to get a radiation EBRT done. As for his lymph nodes, he actually got a supraomohyoid lymph node dissection, a systemic workup, chest X-ray, ultrasound, abdomen were fine, and we last saw him, but I know from his son that he had a disease-related mortality about 3 years from this time. There are other prognostic factors in the AJCC, where it could be sentinel lymph node biopsy, perineural invasion, which can also be other disease modifiers. Finally, this particular patient with a large lesion, this was T3NO and orbital exentration that was done. I know. So finally, I think it is There have been, I think the biggest large series that is there is that increasing, this is from Swati and talks about a fairly large 191, increasing size definitely associated with regional, systemic, and ultimately death related to this. So ultimately, uniform documentation possible with TNM, prognostication is possible, stratification can be based on risk factors and other molecular and genetic factors as they are known can help us evolve the TNM classification. Thank you.